Once unsheathed, you must ensure that the filter does not move or abrade the graft, as this can cause trapped material to embolize or cause dissection. Now you can see that I am bringing a 2.5 into 22 millimeter balloon across the lesion, and you can see the balloon is much longer than the lesion itself. Regarding tips on balloon selection, 1:1 artery to balloon ratio is preferred. Slight oversizing can be done when there are tight restenotic lesions or when you have suboptimal initial results. Longer balloons are preferred for bulky and longer thrombotic lesions, and pressures preferred are low pressures are ideal, but for fibrotic lesions you may need higher pressures. So now you can see that I am pre-dilating the lesion, and then the balloon is removed, and the check shot is done after pre-dilatation to check for any no-flow. And now I am bringing a 3.5 into 28 side stent, again longer than the lesion itself. Regarding stent selection, larger diameter stents, there is a risk of and distal embolization. For the same reason, avoid over-dilatation. And smaller diameter stents, post-procedure balloon manipulations can increase the risk of stent embolization. Stents longer than the lesion length are better, as this will prevent arthromatous material from extruding from the sides and will remain contained by the length of the stent. Now you can see that I am positioning the stent, and the stent is deployed initially at nominal pressures. I do a check shot and then do a high pressure deployment. And the check angiogram does not show any no or slow flow. Now I am planning to capture the filter. Regarding tips on the capture of the filter, partial capture or complete capture are options. Partial is preferred. This is to avoid extrusion of material and distal embolization. Care has to be exercised while retrieving partially captured filter through a stent, as the filter can get caught in the stent, causing extrusion of the material and inability to remove the filter. Careful manipulation of the filter can help in safe removal. Now you can see that I am safely removing the filter as a single unit with partial capture. And this is the final result of the SVG to RCL angioplasty. So tips to management of slow or no flow phenomenon. No flow can occur in spite of using a DPD. This can be because of large masses of thrombi or arthromatous material being collected in the site of the filter. This can be diagnosed by contrast holding up. Intermittent aspiration of the filter can be done with an export catheter. For distal embolization, in spite of using DPD, you can use prophylactic or for treatment, or you can use drugs like adenosine nitroprusside and verapamil. When you use verapamil, a temporary pacemaker backup has to be kept in mind. NTG can be used to relieve epicardial spasm. And now coming to Lima interventions. This is a rare case of kink angioplasty which I did for certain specific reasons in 2012. Why I picked up this case is because this shows almost all the problems you can face with a Lima intervention. Knowing the Lima characteristics is very important in safe performance of the PCI. IMA is highly prone for dissection and spasm, and flow may cease after wiring, producing no flow, ischemia, and infarction. Deep throating of the guide catheter has to be avoided, as it can produce ostial dissections. A second wire can be passed into the subclavian to prevent deep throating of the guiding catheter. This is a JR catheter in a Lima. Lima grafts can be long and tortuous, and hence wiring can be difficult. This needs longer wires, longer shaft balloons, and longer shaft stents. Or you can shorten the guide catheter itself, or you can choose a left radial or left brachial approach. Hydrophilic wires are useful in tortuous anatomy, and you can see that I am wiring this tortuous Lima with a hydrophilic wire. Okay, now the wiring is, hydrophilic wires are useful in tortuous Lima, but it can cause antigradation of flow by spasm and kinking and pseudo-lesion formation due to accordioning. This can make visualization and positioning of the balloon and stents difficult. Stent selection also, long stents there is a problem that you can produce fresh kinks in the curved segments. And short stents are ideal, but then visualization and positioning may be difficult. You can see that after I wired, there is no flow at all. And this patient developed angina on the table. So what I did is pull back the wire a bit, and there is another technique which can be done. You can use external markers like Lima clips or Bonney landmarks, or any stents which are present can be used for references for positioning the stent. You can, this is for demonstration I have showed. I have kept an artery forceps there, just at the site where I want to place the stent. This is one technique. But I had done a vein graft angioplasty earlier, and you can see that there is a stent there.
So what I did was I used that stent as a marker to identify the lesion, and then I positioned the stent carefully, taking care to avoid curved segments, and then I deployed the stent and got a good result. So this is the final result of the kink angioplasty. Now coming to points to remember, do you want me to highlight this or skip? Okay, he's given me 1 minute. So the points to remember are SVG attrition rates can be up to 15% in the first year, and only 40% of the grafts are patent by 10 years. The higher risk morbidity and mortality associated with redo bypass surgery and damage to a patent lemma makes angioplasty a preferred option for revascularization. SVG angioplasty classifies as a complex percutaneous intervention, and strategies and techniques are different from native coronary artery angioplasty, as they degenerated with more extensive and sticky arthromatous disease and a high and for resistant stenosis it's always better to use drug-coated stents. And coming to EMA, the internal mammary artery, they are prone for dissections and spasms. They have a long course needing longer hardware. They are tortuous and prone for zero lesions and obstruction of antegrade floor, which can be modified, which will need modified techniques for visualization and completion. Kink transfer is a major issue to be remembered, but in spite of all these confounders, safe completion of both SVG and lemma PCI are possible, and a repeat CABG can be avoided in these high-risk cases. Thank you.